Thank you. Thank you for joining this morning. Okay, now we're all here, I think.
So my name is Greg Burns, and you have me as the facilitator for the hour, which is a very small role in this case because we have a panel of experts here today, which is great, it's wonderful. 20 years ago, when we started doing this in Maine, there weren't many of us involved in pediatric palliative care, and now there are more, and it's wonderful. So I've been in pediatrics for 30 years in various different roles. My current role is I am the lead nurse for pediatrics and palliative care for Northern Light Home Care and Hospice. And I currently kind of traveling up and down the state, helping get a pediatric program kind of rolling in our state. And so we have offices in South Portland, Waterville, Ellsworth, Bangor, Holton, Presque Isle, and Fort Kent. So up and down through those offices. And currently we have 3 patients in our Bangor hospice program, which is really kind of a high number for us right now, but we're moving in the direction of getting more and more pediatric roles all the time. So that what I've always known about pediatrics is that the kids are out there. It's just that their access to services has been so limited. And I think what we all find as clinicians doing this work is that some of these kids have been out in the community for long periods of time without care, only care by their families or their parents or primary care physicians. So accessing these services is really what we're here to kind of talk about today too. So we want to talk about palliative care in general, pediatric palliative care in general. We're going to talk about current services, and then we're going to talk about brainstorming how to kind of like improve access to those services that are there. And this is our expert panel, and I would love to have them actually introduce themselves because I mean I do have bios on all of them, but I think since we're such a small group here, it'd probably be best to do that. So Allison, let me start.
Sure. My name is Allison Caldwell. I am the pediatric palliative care physicians on the pediatric advanced care team, Maine Medical Center. And I've been there for 5 years after doing a pediatric residency and then a pediatric palliative care fellowship. So from New York originally, that's good. Yeah.
I'm Shirley Jacobs. I'm the pediatric palliative social worker on the PAC team at the Medical Center, and I've been there for almost 5 years. And then prior to that, I was the pediatric social worker through the Maine Healthcare Home Arm, Southern Maine region, doing family visits for kids with medical complexities. Prior to that, just like a blend of pediatric kind of clinical mental health and kind of pediatric palliative care in the community, and also kind of a blend of child life training as well.
I'm Rachel Burgess. I'm the nurse practitioner on the palliative care team at Maine Medical Center. I've been here for now almost 3 years, I think. I used to be the newest member of the team, but not anymore, which is very exciting. After 3 years, I'm not the newbie anymore. Prior to coming here, I was at Boston Children's Hospital doing the same thing as pediatric palliative care practitioner for a handful of years. And then before that, I was a bedside nurse in North Carolina at UNC Chapel Health, oncology pulmonary nurse.
And we I was going to go through some slides today just to kind of like get things going. But I think it probably won't take a huge, the whole time, of course. And so we can save, a good chunk of time at the end for just kind of like any questions you guys might have or any interests you might have to kind of like focus in what we talk about. All right. So we introduce ourselves. We'll be talking about pediatric palliative care today. We do not have any conflicts of interest to disclose, other than we care a lot about
Our objectives will define pediatric palliative care, describe the population that we take care of, distinguish some key features unique to the field, understand the current state of pediatric palliative care in our particular geographic region, and then discuss some current challenges and also opportunities around access to pediatric palliative care in Maine. So pediatric palliative care, this definition is sort of like a combination of both the WHO and AAP's definitions, and it's the active total care of the child's body, mind, and spirit that also involves giving support to the family. This should begin when an illness is diagnosed and continue regardless of whether the child is receiving treatment that's directed at the disease itself. It always requires a broad, multidisciplinary approach that includes the family and makes use of community resources. And pediatric palliative care is provided in tertiary or quaternary care facilities, as well as community health centers and in the home setting. So it really spans kind of location of care as well. And sort of like in a nutshell, some sort of key features that feel important to kind of pull out today for you guys. One is that in providing pediatric palliative care, we're really caring for young people ranging from the prenatal to young adult. And so sort of like there's an incredibly broad sort of like age range and spectrum that we're treating that, spans caring for parents as they're receiving a difficult or complex prenatal diagnosis and making a plan for what delivery and newborn care will look like, through our young adults who are actually like transitioning from the pediatric world into the adult world. We're a team that will sort of follow them through that to provide support as they're really like coming into their, sort of like sense of self, decision making, and really sort of like gaining the legal ability to sort of make independent decisions for themselves. We also know that childhood serious illness and death are relatively rare and caused by a very large number of rare conditions. And so while this is such an important field for that population of patients who are walking through this, it is something that it is occurring still rarely, and that any one given sort of pediatric provider in the community may not have a huge amount of experience with unless they are sort of, kind of seeing a more condensed kind of population of children accessing this type of care. We also know that the kind of conditions the children we're caring for really sort of like broad ranging, and so encompasses some rare kind of genetic conditions, and like kind of even in one sort of medical condition, two patients that have the same thing might have kind of very different appearing courses too, which is important to note. One piece that we're going to really hone in on today is the concept of concurrent care. This is sort of like the central philosophy of pediatric palliative care, and also has impacted kind of how care is delivered as well. So we'll come back to that later. We touched on this a little bit, but we know pediatric patients under 18 years of age are most often considered to lack capacity to make serious medical decisions, and are also unable to provide legal consent. So we think a lot about how we're kind of involving our pediatric patients in decision making in a way that looks very different than kind of in the adult population. We know that family dynamics and developmental stage of our patient impacts the care that they're receiving. We also really appreciate that care requires an extremely wide-reaching interdisciplinary team that we'll talk about as well. In the pediatric world, there's a growing body of evidence for symptom management and also a very high prevalence of medical technology. So kind of like all of this to say, these are sort of, I think, some of the features that really kind of like define the patients we care for, and sort of how we approach their care. And we'll dig into some of these a little bit more, but I'm going to pause there for a second and just see if you guys have any thoughts that came as we kind of have been talking. Okay, great. Yeah. All right, so we'll think a little bit more about kind of who are these patients. So first of all, we know there's a growing population of children who have complex and or chronic medical conditions, and that is going to keep growing as time goes on, as we have, so many factors play into this, but increasingly sort of our ability to take care of
very premature babies when they're born. It's improving the medical technologies and medications and therapies that are available to children with serious or complex illnesses are kind of growing, expanding, and improving. And so I think, even in our own sort of like practice, our own careers, I think we'll see that kind of shifting over time as children are living, longer with complex medical conditions. We also know that every year we do have pediatric deaths. And so this data comes from the CDC in 2020. And I won't kind of like read through it, but you can see there that obviously infant mortality, that's the highest population of pediatric deaths and often is related to preterm birth and congenital issues. And then as children get older, cancer and accidental or injury-related kind of deaths become more prevalent, unfortunately. And so just to kind of, really, impress on everyone kind of this population that's so important to have kind of specialized care for.
And these are main numbers or the
No, this is
the
national, CDC
right.
data, yeah. Mm-hmm. So another way to look at this is sort of like who are the patients who are actually receiving pediatric palliative care. So this comes from two different sets of information. So on the left, we're looking at information from a prospective observational study of all patients who were served by 6 hospital-based pediatric palliative care teams. This study came out in 2011, so a little bit older, and the 6 teams were in very, very large pediatric centers, larger than what exists here. And the predominant clinical conditions identified in that study included genetic and congenital, neuromuscular, cancer, and respiratory illnesses. They appreciated, as we've already pointed out, a very broad age range of the patients they cared for, significant exposure to medications, a very prevalent reliance on medical technology. And I think like at the time, 2011, what was like really significant and sort of, I think like, made this a really powerful study was that 1 year after entry into the study, more than 2/3 of patients were still living. And this kind of reaffirmed what pediatric palliative care teams had been seeing, which was that children with these serious medical conditions were living longer with these conditions, and truly, like hopefully for many reinforced that pediatric palliative care is also appropriately being involved kind of early on from time of diagnosis rather than sort of at the most advanced stages of an illness. And then sort of fast forward time a bit, on the right, the diagram is from the most recent sort of pediatric palliative care survey that came out of CAPC and really highlights kind of more recent top diagnosis categories that included cancer, prematurity, neurologic, congenital, and complex and chronic. And so there's a little bit of a shift from that 2011 study, and hard to know if that's related to just sort of like how they categorize things. But I do appreciate that they include prematurity here, which is a huge population of patients that we see, and also a category that like sort of includes or encompasses the sort of complex and chronic conditions that patients might face. So in order to kind of take the best possible care of these patients, provide them the standard of care, it requires an interdisciplinary team. And so obviously we have sort of a small interdisciplinary team ourselves within pediatric palliative care at Maine Med. But every single day we are working extremely closely with our patients and their families, nurses both in the hospital and in the home setting, other physicians on their team, both primary care and specialty focused physicians, child life specialists, chaplains, PT, OT, and speech therapists, again, who might be in the hospital, but also a team in the home setting or in the school setting, pharmacists, parent mentors, case managers, and then of course schools, which we always think of as really kind of, the center of so many of our patients' lives. So important to include in these discussions. And as we're sort of taking care of pediatric patients, this is kind of sort of like a schematic that highlights what a typical pediatric trajectory of serious illness might look like. Obviously, this does not apply to every single patient, and many of the patients we meet might go on to have resolution of their medical condition. But for those who do have a chronic and progressive medical condition, we appreciate that they are going to have sort of an early acute illness where they're receiving kind of difficult news about their diagnosis, and then throughout their lives, at that point might recover and then accommodate to kind of a new baseline or a new life or kind of what life looks like. And then kind of throughout their life might have sort of these periodic periods of acute illness and unexpected recoveries until they are facing ultimately end of life. And so you can appreciate that at each of these kind of different junctures in time, having a team that's sort of following longitudinally through really appreciates a family's goals, their beliefs, kind of what they're hoping for, holding for their child would be sort of absolutely essential to walk alongside them. So that takes us to this concept of concurrent care that I mentioned we would come back to. And so as we think about really meeting a family at time of diagnosis and following them through that journey, this is really the philosophy of care that sort of, kind of like emerges out of that. So this is a philosophy as well as an organized method for delivering compassionate and consistent care to children, and really means that just as we're providing kind of curative or disease-directed therapies, that right alongside that, we're providing palliative therapies, or those that are focused on a child's quality of life and comfort. And this picture on the right-hand side just sort of shows the evolution of that kind of in the larger field of palliative care. That maybe sort of like many decades ago, palliative care would become involved when there were no further like curative therapies possible. And it was really sort of like two distinct separate fields. And then eventually, potentially they became a little more integrated, and as curative therapies became less and less available, palliative care would sort of gradually increase its involvement. And then the third category here is what I'm describing, which is that as we're providing cure-seeking care, life-extending care, we're also always providing quality of life and comfort-maximizing care alongside family support, tending to grief and other emotions, and support for the healthcare team. And that all of those things really need to go hand in hand to support a child in living as well as possible kind of throughout that experience.
It's great to see the evolution.
Yeah, it's really
of
interesting.
model.
Yeah. And this is kind of another, I think more of like another philosophical way of looking at that. This came out of pediatric palliative oncology literature. And really, I think I like it because it highlights that this applies to patients both who do survive and those who do not survive. And that for families and children walking through those experiences, they need to be provided continuous, iterative, and individualized blending of care that's directed at their underlying disease and their physical, emotional, social, and spiritual needs. And that really, while we're supporting a family's hope for cure, for life extension, hope for potentially even a miracle, we are always at the same time supporting their hope for comfort and meaning. And those two things do not have to be separated. They really, truly can and do exist at the same time. And so that's, I'm just going to say that's really kind of at the heart of what we're always thinking about and trying to achieve for the patients and families we're caring for. So I mentioned that this has really practical implications. So we'll talk about that moving forward. So what does this mean for sort of medical resources for the families and children we care for? So we know that historically families actually faced a choice between continuing curative therapies or disease-directed therapies and hospice care. And you could not access both disease-directed therapy and hospice care at the same time. In 2010, the Affordable Care Act came into existence. And there's a small section in there, Section 2302, that though small made a huge impact in pediatric care. It's called Concurrent Care for Children. And this required all state Medicaid programs to pay for both curative and hospice services for children who are under age 21 and who qualify. And this means that a child who is eligible for and receives hospice care must also have all other services provided or have payment made for services that are related to the treatment of their condition. So just boiling that down, what that means is that a child who qualifies for hospice may choose and elect to be on hospice while also receiving curative or disease-directed therapies at the same time. And there's not a choice that has to be made between the two, and that child's receiving state Medicaid, that both will be paid for and reimbursed. And so this affects all children eligible for Medicaid or other CHIP insurance programs. But in general, many/most private insurances have sort of fallen in line behind that. And in Maine, most all children that we care for either already have in place or do qualify for Maine care based on their medical condition. So it varies state by state, sort of like how that works. But in Maine, that's kind of very well set up. So. There are still limitations and challenges of this. Specifically, it doesn't reduce barriers to providing more expansive pediatric palliative care services for children who don't qualify for hospice. So to qualify for hospice, you do have to have a prognosis of 6 months or less if the condition were to follow its normal course. So for children who are living, long and even many, many years with these, types of complex and serious conditions, there is not sort of a reimbursement for home-based palliative care services. While families are able to access that in a hospital setting or in a clinic setting with a team like ours. Greg can speak to this kind of best of all. There is not consistent reimbursement for kind of home-based interdisciplinary palliative care teams. We also know that children, yeah, go ahead.
I was just going to say, I don't know if you've included this, Allison. I didn't look beyond this, but do you want to talk a little bit about the meetings that
we should, because it's important to note that hopefully may be changing like in the coming year or so, which is really exciting.
Mm-hmm.
So yeah, we'll talk a little about that at the end. So we know children who qualify for this benefit are also limited to the existing array of hospice services and other existing Medicaid services covered by the state. That is very important in Maine because we live in an extremely rural and like very geographically spread out state. And so while a child may qualify for hospice services, it may be really difficult to find a team that's even able to kind of take care of them or take them on. And when we do, as we all know, like the ability of that team to sort of consistently have an interdisciplinary team available or have sort of pediatric, specialized team members available may be sort of like limited by where they are and what their kind of resources are. So we also know this requires collaboration between hospice agencies, the child's team of medical providers, and those at the state Medicaid agency to really distinguish between what's considered curative and what's considered disease-directed therapies. And what might be directed at palliative symptom management. And I included, I didn't know exactly who would be here today, so I included this, this is not for anyone to really read, but this is a helpful schematic of how, say, a hospice agency might walk through and say, okay, this child is on X, Y, or Z medication. Is this something that should be covered under their hospice benefit, or is this something that really should be part of their kind of typical health insurance coverage? Because I think it's such a balance and really so important that that really both kind of like arms of a child's kind of Medicaid coverage are accessed so that there's sort of like a balanced use of resources. So. Not really something to kind of dig into today, but just to say that there is kind of a broader discussion, even nationally in the pediatric palliative care world, of like what falls under what bucket of care.
Right, I'm sure. Hannah,
yes, that probably feels very relevant to you. Yes. Yes. And
we have access to this stuff.
Yeah.
I have this actually.
Yeah.
You do this very thing. Yeah, it's very helpful. Yeah, it's super helpful. Because you can imagine, you could speak to this better than anyone, but for example, a child who maybe for many years of their life has had a feeding tube in place and receiving nutrition through that tube, that's probably going to fall under a category of something that's a life-sustaining therapy and not something necessarily that would fall under their palliative or hospice sort of focus of their care. So just one example, but important to parse through that. So where do pediatric palliative care programs exist? And I show this just because it is exciting that Maine's sort of on the map there. I feel very proud of that. But as you can see, it's not huge. So still fairly kind of specialized field. And so what does this look like in Maine? So we, as Greg pointed out, there has been a growing access to pediatric palliative and hospice care throughout Maine and New Hampshire, despite the significant challenge that's posed by our very large and geographically broad state. We also, I mean, even in the past 5 years that our team has existed, we've appreciated that there is a rapidly expanding population of pediatric patients who are facing complex medical conditions. And I think right now, as it exists, we have really well-established kind of just-in-time education and specialty pediatric palliative care services to support pediatric hospice patients, kind of no matter where they are in the state, really like providing like real-time support to a hospice agency that's kind of taking on these patients when they may not have like a huge amount of experience with pediatric patients. And sort of moving forward to expand that, we continue to expand access to pediatric palliative telehealth support, and that's been, I think, one of like the few, if any, silver linings of the pandemic is that telehealth has become like such an accepted modality, and for a patient and a family who might be traveling really far distances with lots of medical technology and have many, many medical appointments in a given month, that hugely improves their quality of life to have access to that.
And acceptance to have that service.
Yes.
One of the bigger things that I've
Totally.
They're more willing because it's not another visit that they have.
Yeah, exactly. It just like it decreases the strain of that. We also continue to think about expansion of continuous community-based pediatric palliative interdisciplinary services, and that's what Greg was kind of referring to, that right now at the state level, there is an effort to basically expand reimbursement for interdisciplinary teams in the community, which, I mean, for us, it would really impact in the community.
i.e. a palliative care benefit.
Exactly, a palliative
Like the
care
hospice
benefit,
benefit.
yeah.
Right.
Which would be hugely impactful, and that applies for both adult and pediatrics. So we've been trying to help provide sort of pediatric lens to that effort.
And that actually goes hand in hand with the adult effort to
Yes,
do that
exactly.
same thing, which is really forward-thinking of
Yes.
main care.
It's really exciting.
To include pediatrics at the same time.
Yes,
is a
exactly.
Really excellent.
It's
way to
really
think about
good,
that.
yeah. And then something our team is hopeful to kind of continue to afford within the coming years is creation of a pediatric hospice consortium in our region that really like moves past this sort of like just-in-time, patient-by-patient, case-by-case support, and really moves to more like standardized approach to pediatric hospice in the state, and really like brings teams together that might, at any one time have one or two pediatric hospice patients, none for large swaths of time, and really create more of a like shared sort of like dialogue around how we're caring for those patients, and really like a community around that to build, I think, that confidence. And then Shelley and Rachel can speak to this further, but they are deeply in the midst of a pediatric respite needs assessment as sort of another, I think, often overlooked, but like highly important aspect of pediatric quality of life and family quality of life that we think about a lot in our team. And so I know I'm kind of flying through this, you guys, but we'll talk after this and answer any questions. And so kind of like, why does this all matter? And I just put some sort of like, closing slides here to talk about like why this is important or why this is impactful. And pulled in some kind of, well-known pediatric palliative care literature to help us with that. So for one, we know children who receive concurrent and end-of-life oncology and pediatric palliative care are significantly more likely to have fun, experience events that add meaning to life, and also to die at home. And that's one of my favorites. We think a lot about a pretty broad definition of quality of life, and really often that means like, how do we help a little person feel as happy as they can every day? And so that always really like speaks to me. We know that patients receiving pediatric palliative care consultation have had more and earlier end-of-life discussions and greater hospice enrollment. And then enrollment in home-based pediatric palliative care and hospice is associated with lower hospitalizations, ER lengths of stays, and total hospital charges for children with non-cancer diagnoses. So potentially this expansion of palliative care to the home will be really huge here. We also know that patients and parents really value focus on quality of life beginning at the time of diagnosis, and that few identify negative attitudes towards palliative care. So sort of like kind of moving away from like maybe some of like the more historic stigma around what palliative care can mean for people. And that really like parents and kids are like, yeah, we would really welcome that support around our quality of life and our well-being and comfort. We also know that involvement of pediatric palliative care in the home is perceived by parents as really contributing to improvement in child's symptoms, quality of life, communication, and reductions in barriers to care. And that I'll kind of end there because I feel like that just like kind of says it all in a nutshell. And it's really what we're working towards. So I think that's it. So I'm gonna pause the like didactic portion of this now. Thank you guys. And maybe we'll do our more of a panel discussion now. If that's okay.
So in your, tell us a little bit about your experience in referring out in Maine. And like, how has that been, as related to your slides and all that kind of stuff? How has that experience been? What's out there?
Yeah, in terms of like in-home services.
Yeah.
I can do it.
I'll
start. I would say first of all, it's really significantly improved and changed I feel like even since like I started and you kind of shifted over to Northern Lights, like in the past years, it has improved. And I would say in that now, I think we can, if we are caring for a pediatric patient who requires hospice services, we can kind of reach out to our partnering community agencies and have a really open discussion about kind of what's going on with that patient, what their needs might look like, and kind of a really honest discussion about like what resources that team might have to support the family, and then I would say like in most cases accept them, and so I'd say like that's huge because when we started doing this, most hospice agencies had not taken care of pediatric patients.
I don't think that had occurred.
Yeah, I don't think it had.
5 years ago.
Yeah.
I don't think there had been like an official hospice enrollment for a
Yeah.
pediatric patient prior.
I think just like as we kind of like touched on and what hopefully is going to change in Maine is that like accessing sort of home-based palliative focus services for kids is still a huge challenge because ultimately, and again, Greg could probably really speak to this, but ultimately there isn't sort of kind of financial support or reimbursement for formal home-based pediatric palliative care. And so it sort of gets created out of the realm of like skilled home nursing care. And unfortunately, even when a child has incredibly complex medical needs, they may not have a specific skill or thing that's changing that qualifies for them for that. And so while in an ideal world, you'd imagine that a palliative home team like us would be in the home, following that patient longitudinally through the course of their illness, building a relationship with that family, present for both the times that they're well and at their baseline and times that they're sick. Unfortunately, especially during the times that these patients are kind of at their well baseline is the time when nursing agency has to say, actually, we have to leave now. So you end up with like this kind of choppy care that kind of really only exists when there's sort of an acute issue going on. Does that feel like it kind of sums it up well?
Sure.
And that's really the challenge, I would say. Yeah.
So currently, from my own experience, just talk a little bit about what's out there and what's currently going on. So I know, I can speak intimately to what's currently going on at Northern Light. But I also know, so at Northern Light, we're currently in the midst of creating a statewide kind of pediatric program. So the beginning of that has been kind of trying to educate some of our clinicians and to work on bringing pediatrics to our agency. And in the midst of all that, COVID struck. And so right now, and that's one of the things about this conference that is just feels so good to me is this right here, is this ability to kind of sit and look people in the eye and kind of talk a little bit about what's actually going on, where we're at. But also, it's kind of a jump start to kind of like, okay, this is the kind of thing that we need to be doing more of, this discussion and kind of how to kind of like get this rolling a little bit more. So we are in the midst of kind of trying to kind of boost our pediatric presence in all of our offices, so the offices that I discussed. And so we currently have, due to the fact that our administration has been very supportive of pediatrics, we have positions available in all of our offices that were now one of the other challenges that we didn't really talk about is actual personnel to try and do this work. So that's another piece that we've really got to kind of try to work on. And as you pointed out, Allison, I think that education piece, that consortium of folks that have the knowledge and have the ability to train, getting those folks to the people that want to be out there doing the work is going to be really important as well. So that's the other piece that we are, I think that's where kind of we're at right now. We're in this place where we've got some really wonderful people that are out there and able to do the work, but we also have open positions that we're trying to fill with folks. And so that's very, very difficult. So that's Northern Light. Anything else you want to speak to?
Well, I was going to say one of the biggest things is, so I've been in the position for a little over a year now, worked for home care and hospice, did pediatrics I was the only one in the office that would touch a peds patient, like wouldn't do it. And I think it's still kind of the same stigma of like, and it is unfortunate people do look at it as they're a tiny person, and in some ways they are, but they're very, very different. We know that their buildup is very different. But one of the biggest issues is I've worked very closely with Cancer Care of Maine to work with their pediatric oncologists and things, which is why we've had so many patients in that realm. But it's so true. There's no mid ground. I always say that like there's home care, then there's this bridge of palliative, and then we're going to transition to hospice. And unfortunately, because of the lack of palliative care that we'll see pediatrics, especially in that area, we're in this. Yes, it takes a weight on the hospital, but it takes a huge weight on the pediatric population of cancer care. They have 2 providers there. So if they're trying to transition their patients to hospice and there's no palliative in the middle, they're wearing all of that palliative and cancer care provider piece until they can come to the hospice realm. And it's a huge gap. And I mean, it's a gap in adults as well. We see that, but in peds, there's this huge emptiness of our providers, even not in cancer care, but that are taking care of pediatric patients, are trying to manage their pain and their symptoms while they're in this palliative section, but no one to care for them. And it makes the transition for parents, unfortunately, more difficult to come to hospice. When they're on palliative, it's a lot more, not easier, but you have that sort of care and team. Yeah, they have those conversations. You're constantly revolving around those. And so when hospice comes up, it's not the deaf people. It's not just like this sharp turn into, and it's funny that you say that because it's not something that I've ever really thought of, not having a palliative team in pediatrics, but it is a huge piece of.
It's like the ideal, right? The ideal world is that there is this like palliative care team support that really like follows a child through that process, and that transition to hospice, it sort of like occurs within that same team, so that they're not losing team members. They're really gaining additional support and additional expertise while still kind of carrying that palliative care.
Well, and like when I think of it, just like as a graphic, really think about that concurrent care with those graphs. It's like, you know, if you only have hospice, you sort of have to go from that more curative care, even though we know concurrent care and policy exists. In families, the shift is from this type of care to this type of care, but with palliative care, you really can't like have that sort of seamless, like moving through that process of like constant, you know, reevaluating kind of what.
I feel like that's one of the things that I'm so appreciative of our hospice is that we've been able to I think on the fly a little bit. And our director, Chris, is very kind of aware of the concurrent care piece and how we can have home care and hospice involved in the same patients. And so that's
Getting creative about the resources.
very creative. And I think that's where the future kind of lies for agencies that don't see a ton of kids, right? So it's important for us to kind of like encourage that kind of, I think, behavior almost in other agencies. I was going to say the other agency that I have some awareness of that's actually doing some pediatric work is Scoggin Home Health.
Yes,
And I'm sure you guys have worked with them.
Yes, we work with them, and Hospice of Southern Maine has actually started to accept some pediatric patients.
Right. And we've actually had we have a hospice house up in Aroostook that's actually taken on some pediatric
Wonderful.
patients.
That's
as
actually,
well.
they were getting ready to take one of our pediatrics. She's now 3 months old, but when she was a couple weeks old, they were very anxious. They were very unsure. And as you know, there's no pediatric bed. It was like, where do we find a crib? How do we, meet these needs? That was gonna be one of my questions is the respite. Like, there's no place for respite.
Yeah.
There's not. There just isn't. Nobody wants to take them because you think about adults. It's long-term care. They'll give us those beds for a couple weeks. Yes. But it just, there's no. It doesn't take on a patient for a respite stay. It's a huge gap. Yeah.
I think one of the things that I have seen in traveling up and down the state, and we heard a little bit about it last night when we heard from the folks from Jackman last night. There were some folks from Jackman here who were talking about what it's like to be on the ground in a really rural area where there aren't a whole lot of choices, and how excited they were for telehealth and for things like that. I think that is the key, opening of a door that we need to kind of like kick open and really kind of get that rolling. But that piece, and I was thinking as you were speaking about the hospice house up in Aroostook, and yes, there was a little bit of fear and a little bit of worry, but there were also a couple of nurses there that I've known for almost all of my career, and who have seen kids when they've needed to.
Yeah.
You know what I mean?
Yes.
And that's really the people that we need to. And granted, some of those folks are getting ready to retire and all that kind of stuff, but we need to kind of like to really to nurture that piece of resilience and encourage the folks who really want to help out with the pediatric program, to let them know that there is support and there is training and there is.
Like envisioning this consortium, like almost like if we could create this like network of hospice providers, and I think hospice is the place to start with that. Obviously, ultimately more like community-based palliative care as well, but hospice is what exists right now. So kind of starting there and creating this like really like network in Maine of who are the groups that are taking pediatric patients, who's thinking about taking pediatric patients, and sort of like using that like shared experience to build confidence, but then also like I think help people understand they do have access to teams like ours that are thinking about this all the time. And so like they can call us on any random day of the week and ask for help with something, and that we would, gladly provide that if it means that, again, like a child would be able to access that resource.
So I think what I've appreciated over the past few years is almost just like a shift in openness into kind of the consideration of kind of taking on a pediatric patient, and I think a shift in like we can be creative and we can find ways of kind of putting these pieces together and finding enough support to kind of support the child, making it is still kind of consistently inconsistent.
Yes.
Depending on like geographic reason and staffing and just providers who have maybe turned over, or so I mean those pieces continue to be inconsistent. Yeah, like generally I feel like there's more of a spirit and energy of like we want to figure this out.
Yeah.
And a little bit more confidence. I think there's like some footing around kind of like, oh, I think we can do this. And kind of I think that's kind of taking hold a little bit.
Some of those tenants I think have been around for, I don't want to go back in the day, but and yet, there are people who started doing this a bunch of years ago, and Gary being one of them. And Kelly and I, we went around the state and did that kind of education, kind of piece by piece by piece, and it's almost like that's still kind of the way to do it in these rural areas, but we do have tools now that we did not have back then.
Totally.
And telehealth is one of those tools that I think we really do need to kind of like, and as you say, Allison, kind of creating that network, I think is really important, both in the physician community and then the wider clinical community as well. But
Yeah, when I say, I mean more like with like community agencies,
Yeah.
like linking like Northern Lights and Androscoggin and HSM and Maine Healthcare at Home and the coastal, like creating a link between all of those groups that are doing this, because I just, if, HSM had 2 pediatric patients recently, you guys have 3. I mean, it's just, there are these tiny pockets of patients, but if you sort of add all of that up, there's actually, there's more patients than we sort of like any one place really like appreciates that there are. We can like kind of combine forces in a way is what I was thinking. Yeah.
Share strategies.
And
And I think if that network was in existence more and there were more resources, there would be a lot more kids,
Yes,
right?
there
Like,
would
we
be,
would,
yeah.
I mean, we could probably,
Think of,
three of us could think of, like, we could just start listing them and
Yeah,
think of kids that we think would really benefit from, either earlier hospice referral
Yes.
or a palliative, community-based palliative care referral.
Well, and the funny thing is we've actually, it's the most we've seen in years, like the Bangor team in the last year has had 7 pediatric hospice patients. And really the network is the huge piece. And I don't even think, like Greg said, I think 98%, I'm gonna give that a wide range, but of the hospice nurses, if you said to them, like, we have a pediatric patient that needs to be cared for, but they have a little bit of resistance, but they'd be like, absolutely.
they would be nervous. but
Yeah,
they
but
would-
like, there's
yeah.
no way I'm letting a pediatric
Yes.
patient not have this.
Yes.
But it's more than, it sounds funny, but it's more of like the management and the teams and the, they maybe don't feel like we have the training or the resources or the access or.
And understandably also, I think probably want to be protective of their staff too,
Right.
at such a hard time. Yeah.
So those are the biggest pieces that seem, I mean, one of the things is we happen to be taking care of a 21-year-old pediatric patient. And that's kind of what opened the door is like we got a very close connection with cancer care. They really appreciated the way that the team cared for that. And then it opened the conversation of like,
That's wonderful.
what's the age and what can you guys do? And though we talk about it, it's something like concurrent care, and still being able to do those things. A lot of the newer providers at cancer care that do pediatrics, they were like, we didn't know they could do that. We would have referred more patients. Like, it's
That's
not
really
education,
Wow.
yeah.
So we've done a lot of education on that because it wasn't something that they commonly knew. One of our patients that we had that was a 3-year-old, she every other week was going to the hospital for 4 days to get immunotherapy.
Exactly, yeah.
Then she'd get shots for a week when she was home, and it was like, that is something that you can do, and a lot of people don't think of it like that.
Yeah, absolutely.
I know we've only got a few more minutes here, and one of the things I'm curious about is you three, actually. I'm curious about like what your impression is of this, of the presentation, and but also thoughts about things that you may have seen in your experience and what you're thinking as you're hearing all of this, because this is something that a lot of us have been doing for a bunch of years.
Yes.
And I know I am like keen on hearing new ideas and thoughts and feelings about it,
Yeah. Well, I can tell you, I trained in general pediatrics in North Carolina, and then I worked as a hospitalist in New York City before I went back to North Carolina for my fellowship. And North Carolina and New York, both states that have concentrated academic centers with very large rural outpostings.
Absolutely.
And I was very struck by how concentrated, highly specialized pediatric care was in both of those places. And so, if you live in Manhattan or you live in Raleigh, Durham, you can access anything under the sun in terms of palliative care and peds palliative care. I mean, a little bit exaggerating, but it is available. And if you go 3 hours outside of those places, it's not. And so actually part of my reason to come here and to apply for working with these guys is because of the emphasis they have on wanting to treat the whole state. and figure out how to work as a team with other people, other organizations within the state. And so I think that while it often feels very frustrating, like, why don't people understand that we need all these resources thrown at us and we need money and people, it's also like, I've just been so impressed by how I think ahead of the curve
Sure.
you all are in like your prioritization of where you want your programs to go. And listening to you guys talking about concurrent care models, like, I'm really curious to learn, like, what are the barriers to utilizing concurrent care? Like, are people using it? First of all, like, how many kids who would qualify are getting it, right? Like, I'd love to know that number. I don't know if it exists. And then if they're not using it, which I suspect they're not in many cases, why? And like, what are the reasons on the family sides and the provider sides? And I'd just be very curious about that.
I mean, I can tell you just from experience, I think probably a huge portion of that number would be because of education, because of educating clinicians and parents and, you know, kind of like the wider kind of public about it a little bit. Because as Allison pointed out, it's this little provision that's kind of written into the whole big, you know, bill, and it's there, and to us in pediatrics, it's kind of glaring, you know, but for a lot of other folks, it's not.
Something I think, like, when we do have a patient who's accessing hospice, and really, I mean, for so many reasons, has a strong sort of like concurrent care based plan, you have to just like keep a hawk eye on it, because like, for example, we had a young man who had Duchenne's who was on hospice, had a relatively uncertain prognosis, though was obviously extremely ill and at the advanced stages of his illness. He needed his wheelchair updated, and his family was working on that process and heard a no from a wheelchair agency because he was on hospice. And so we had to sort of like first learn that this had happened and then call that agency and tell them, like, teach them what concurrent care was. And then they were like, oh, well, in that case, we didn't know. We'll put it through insurance. And they had just sort of like said, we won't put this through insurance because they thought it would be denied. So just sort of like, I think that's like one tiny example of like the challenge is like, you know, you almost like put a family in a situation where even though we're saying one thing, 10 other providers that they're interacting with to access like a vital kind of therapy for their child is like saying no. So it's like, it's a lot of work, I would say.
Well, and then it delays an already long process, you know, a process that already takes a long time.
Yeah.
And then adults and peds, I think one of the biggest things that I've heard is like, well, how much is that gonna cost? Like, are we gonna pay for that out of pocket? Yeah,
Exactly.
insurance doesn't
Yes.
cover it.
Yeah.
And so for a lot of parents, they know immunotherapy costs thousands
Yes.
and thousands and thousands of dollars.
It's terrifying to
Right,
lose that.
and because a lot of people have that as an adult when you're on hospice, those things all stop.
Yes.
When a pediatric patient comes on, that's some of their resistance to even coming on is they're like, well, if we can't do treatment, like, even if we can have 2 more weeks with our child, we wanna get
We want
that.
that.
So they kind of don't, and then
Yeah.
sometimes we get them too late because they don't know that they can have that care continuing.
And I did wonder about addressing, like, on the provider side, some discomfort with caring for kids. If kids were getting enrolled earlier in their course of illness, part of me feels like that would ease some of that distress about caring for that child, because there would be time to get to know this family in their more healthy state and not non-crisis state. I did wonder about that.
Absolutely. Agreed.
We like walked through that scenario recently, and it's interesting because I think the hospice team, I think that was very accustomed to a very adult population that oftentimes is accessing hospice late in the course of their disease, was sort of like initially like, well, we're here, but like we feel like we're not doing anything. And I think there was some distress around feeling like they needed to be sort of like doing something when this young man was fairly stable. So we just did a lot of actually like kind of like talking through that, coaching around what they actually were providing, even though it wasn't always a super tangible item. And sort of like fast forward many months, that young man just passed away, and like we've just had an outpouring from their team about like what a meaningful experience that was and sort of like has changed their practice and been super impactful. So just that was like a really, just a recent kind of experience we had that I think like speaks to that for sure. Yeah, maybe shifting that framework for people.
Yeah, and I think that, I mean, you know, as with any movement in anything, I think that what we need to do is multi-pronged, right? I mean, so education is only one prong of the kind of move forward, and but I also think that you know, it is important to have that administrative support in any organization that you work in. I know Maine Medical Center for a long time, and palliative care team had been talked about and talked about and talked about and talked about, and then boom, you know, it kind of got there. So there was this critical mass that kind of like happened.
Totally.
And so the other piece of this is that you know, the argument that you're going to hear from administrators is we don't have a whole lot of kids. You know what I mean? So why would we put all of these resources into this? And you know, the argument that I end up having to kind of get back all the time is that we would have kids if we put ourselves out there. Not only would we have kids, but you know, the other argument that I always hear is that, and this is a tough argument to hear, but it's one that I have heard, is that the kids don't make the organization a whole lot of money. You know what I mean? And I have a very quick retort for that one, and that is that, and again, I hate to get into the business of it, but the reality is that when you provide this care and you provide it well, it's not the money on the front end that really is there. What it is the community support and that monetary support on the back end. And so Shelley and I have been involved in programs where, you know, when you start to provide that kind of support, then the community gets behind you, then you can kind of move forward in that way too. So, you know, that's another prong, right? Is that piece of not just educating the community, but really showing the community, right? Like what this means and what it means to family, not only families, but to your community to have something like this available in it. So I see we're out of time, and I really appreciate everybody. Yeah. So thank you very much.
Thank you. If you have questions about, you know, thinking about palliative care in the future, just we're available. Yeah. So, good. Yeah, reachable.
Well, and I think keep your ear to the rail too about a consortium type of thing where we do all come together. The people that are out there doing the work. I think within the next year we really do need to. I mean, we had started to kind of like do that type of thing.
I think now that every hospice in the state has actually enrolled multiple kids,
Yeah,
it's like we're
it's
at
time.
that place, right? Like everyone can draw upon like challenges, experiences, barriers, like similarities, and like I think use that like experience to draw together. Whereas before, even a year ago, that may not have been possible. So it's just we're in an interesting place to do that. Yeah.
Enjoy lunch.